This is a University of Otago podcast.
Good evening, I'm Harlene Hain and I'm the Vice Chancellor here at the University of Otago. On behalf of the University, I would warmly like to welcome staff, students, and members of the general public who have all come to share in the celebration of this inaugural Professorial lecture. We are all gathered here tonight to honor the achievements of Professor Wayne Gillett. Currently, he is the head of Women and Children's Health here at the University of Otago. He is also a consultant OB/GYN, and he's the clinical director of the Otago Fertility Services. Professor Gillett has made a number of outstanding contributions to the university, but he has also changed the lives of his patients. In the current PBRF environment, there is not a single researcher in this room who will not be aware of the importance of impact factors in evaluating the perceived quality and value of our research. But I think it's also important for us to keep in mind that the research conducted here at the University of Otago has other important impacts outside the wider academic community. The fact that so many of Professor Gillett's patients are actually here in the audience this evening is a clear testament to the real human impact of his work. I would now like to hand over to Associate Professor David Gerard, who is going to tell us a little bit more about Wayne's path to professorship.
Vice Chancellor, Deputy Vice Chancellor, Professor Taylor, other university colleagues and staff, ladies and gentlemen. It's with a great deal of personal pleasure this evening that I introduce Professor Wayne Gillett, the fifth in a line of outstanding academic clinicians to have occupied the chair in obstetrics and gynecology in the Dunedin School of Medicine, University of Otago. I'm also delighted to welcome members of Wayne's immediate family who are here this evening, with a special acknowledgement to Mrs. Gillett Sr. From what we might today consider a humble rural background, Wayne's proud roots were in Temuka, South Canterbury, where he emerged from Temuka High School as an outstanding scholar. In 1968 at the University of Otago, he successfully completed his medical intermediate year, ultimately graduating with an MB/CHB in 1973. Thereafter followed house surgeon and registrar years at Dunedin Hospital, by which time a career path in obstetrics and gynecology seemed determined. This decision took Wayne to the Hammersmith Hospital, London, a lectureship in O&G, and training in microsurgical techniques under the tutelage of none other than the Lord Robert Winston. Concurrently, Wayne applied himself to clinical and research obligations to the World Health Organization. During his time in London, Professor Gillett completed studies of the ovarian surface epithelium, describing two cell types and attributing the squamous cells to metaplasia from the previous trauma of ovulation, thereby changing the existing perception in the field. And this work, for his higher degree, has never been superseded. Early in his career, Wayne collaborated with social policy colleagues to follow up families involved in third-party reproduction. The lives of these families have flourished, not the least because of these data, and the consequent law changes in many countries, including Australia, Sweden, and the United Kingdom. Professor Gillett has published a major review of chronic pelvic pain, an outstanding work in this poorly developed field, providing sound neuroanatomical and neurophysiological bases for a spectrum of therapies. The rare award of a fellowship of the Faculty of Pain Medicine of the Australian and New Zealand College of Anaesthetists demonstrated their respect for his work in this field. Wayne has provided a long-standing clinical service for a perplexing yet common problem. And here at the Dunedin Hospital and the medical school, he's worked in curricular changes, including the development of the women's health module and the evidence-based approach to clinical practice offered to junior medical students. In May 2012, Wayne Gillett was appointed as Academic Head of Women's and Children's Health, assuming responsibility for the combined departments of Paediatrics and O&G. Simultaneously, he has worked as an O&G specialist for the Southern DHB, and since 1983 has developed and delivered infertility services to a standard that has earned international recognition. By his work on patient pathways, data analysis and decision-making, plus the ability for government liaison, patients of the Southern DHB have benefited immensely. So it's now with great pleasure I invite Professor Wayne Gillett to present his inaugural professorial lecture entitled The 3 Ps of Queen Mary, a celebration of 75 years. Wayne.
Okay. Tēnā koutou, kia koutou, kia hui hui mai nei I tēnā rā, tēnei mihi hi mahana, nui mihi kia koutou katoa, tēnā koutou, kia ora koutou katoa. Thank you very much, Vice-Chancellor and David, for that very generous introduction. It's certainly, I'm standing here very proudly in front of so many friends and family. It is quite a daunting, although it's a privilege to be here. I have a lot of family here, and I want to, with Diane, welcome 2 of our 3 children, Robert and Sarah. I have my brothers and sisters, or 4 of them, Lynn, Pam, Wendy, my twin sister, and Brent, and their family, Bob, John, Sarah and Nicole. And of course I'm very proud to have my dear mother here too, and actually this is the first time I'm giving her a lecture. I want to welcome a number of special guests who will be the subject of this lecture. There are Sally Bromwin and Jane and their families, and there's Professor Dick Seddon, Professor Don Wilson and family, and also the families of Sir Bernard Dawson and Professor Lawrence Wright are also here in the audience. I want to particularly thank John Dawson, who is a professor of the Faculty of Law, and John gave me some valuable material for the preparation of this lecture. I also want to thank Karen Grant, who helped me with some of my research into the content of this lecture. I have one apology from my brother Ross, who offered me some advice. He suggested the first thing I should do is relax the audience. He said, why don't you ask them, did they know that in the Canary Islands there are no canaries? And in the Virgin Islands, there are no canaries either. So thank you, Ross. Apologies, Vice-Chancellor. So why the 3 Ps of Queen Mary? This year, Queen Mary held its 75th Jubilee celebrations, and this lecture is a sort of the last of the celebration functions. There's such a rich history on Queen Mary that I simply had to choose this subject for this lecture. For those involved in childbirth, you will realise that the 3 Ps are a play on words of what we frequently refer to the 3 Ps of labour. But in this case, they refer to the places, people, and patients. For the places, I will briefly recount the history of each of the 3 Queen Mary hospitals in Dunedin. Then for the people, although there are so many I could pay tribute to, I will confine my presentation to the professors that preceded me. All served the university and Queen Mary with distinction, and it is an honour and indeed humbling for me to be now listed beside them. In the 75 years, there have been 4 professors, In the same period, there have been 11 deans. And I finally want to pay tribute to 3 women, Sally, Bronwyn and Jane, and their babies, that I've had the privilege to know and manage their care. Normally, women and babies are represented by numbers and statistics, but in this lecture, I do want to give them an identity, for they represent me and they represent what is Queen Mary. It is not usual to present such explicit and personal information about patients in a public forum, but all 3 have consented for me to tell their stories. They represent many thousands of women who have graced Queen Mary facilities in the last 75 years, and they represent the courage and strength that many women have to face when reproductive health becomes uncertain and frequently unfair. They all deserve to stand on the high pedestal alongside these exalted buildings and professors. And I am indeed overwhelmed that all 3 of them are here today. So where does this story begin? In 1921, James Parr, the Minister of Health, learned that more New Zealand mothers died in childbirth than in any other developed nation apart from the United States of America. In 1920, it was 6.5 per 1,000 cases. He thought these figures would jeopardise New Zealand's public health reputation and appointed a special committee to identify the causes and cure for maternal mortality. There was a public outcry when they learned that the department had known about this for many years. And it was this single event in New Zealand's health history that ultimately led to the opening 17 years later of Queen Mary Hospital in 1937. The direction of maternity care in New Zealand was changed by 2 people, in particular, both influencing the arrival of the first Professor of Obstetrics and Gynecology and the building of a new hospital. The first was Henry Gillett, an obstetrician working in Christchurch who had been the master of Rotunda in Dublin. Gillett favoured the abandonment of New Zealand's 200 private maternity homes to be replaced by large teaching hospitals. He also stressed the need to establish a chair in obstetrics and gynecology at the Otago Medical School and influenced the General Medical Council to require all graduating doctors to have 20 deliveries in their training. The second individual was the dynamic secretary of the New Zealand O&G Society, Dr. Doris Gordon, who in the late 1920s led a nationwide appeal for funds to endow a national chair of obstetrics and build a maternity hospital in Dunedin. And so came our first professor, one Joseph Bernard Dawson, called by his second name Bernard, and later to become knighted for his services to obstetrics. This is Sir Bernard and his family at his 80th birthday. John Dawson is the boy in the front, and his mother Mayford is holding the baby, and Mayford is here today too. This photograph shows Sir Bernard and his wife Nora. In the midst of the slump, Sir Bernard took up his appointment in February 1932 at the age of 48. He was an English graduate and with a great interest in obstetrics from the very beginning of his medical career, and ultimately took him to Adelaide, where he worked as a GP for 20 years. It was this long service to general practice that influenced his own style as a professor and his dedication to teaching obstetrics. Before taking up the role, he made a tour of Europe and the United States to assess, amongst other things, the standard of care that made maternal mortality figures in Europe seemingly better than in New Zealand. He found, to his astonishment, that comparing maternal mortality with New Zealand was impossible. Many countries had not adopted the international causes of death, and he wrote, "Published figures did not reveal the whole story, and that the quality of record keeping and the statistics were so poor that no just comparison could be made with those of British countries." So maybe New Zealand wasn't bad off after all. Now, these excerpts are from his unpublished autobiography, written in the third person using a pseudonym, and give an insight into a man fully dedicated to the craft of teaching and the importance of practical training. I will use some of his excerpts to illustrate the man he was, and for the sake of simplicity, I will convert those to the first person. When he arrived in New Zealand, all medical student teaching was performed at the Bachelor Hospital in 4th Street. This is a photograph I took just a few weeks ago showing that the house is still there. When he arrived, Bernard Dawson found training in obstetrics was dreadful. He found appalling training conditions. The small 12-bed bachelor hospital was substandard, and he described the antenatal clinic as even worse. As a relic of the 19th century, and compared to the hospitals I visited in Europe and the United States, it's frankly appalling. I had the chair, but little else. The other main maternity hospital in Dunedin was St Helens in Regent Road. This was the second of the 7 St Helens hospitals that were opened in the early 1900s, a scheme introduced by the Prime Minister Seddon for the dual purpose of training midwives and providing maternity care for mothers struggling to rear families on small incomes. Ultimately, very few medical students were allowed in St Helens hospitals, and so only women students. To increase his students' practical experience, Sir Bernard took it upon himself to personally supervise almost every delivery attended by medical students. He got into the habit of being summoned as soon as possible after the onset of labour to ensure as much as possible of the phenomena of childbirth. And he wrote, this lasted 6 years with no doubt irritability when tired. He was affectionately known as Bernie by his students and frequently engaged in what he called the 4th stage of labour. The first 3 stages happily completed, he enjoyed a cup of tea, hot buttered toast with discussions, reminiscences and yarns. To increase attendance at antenatal clinics, Sir Bernard introduced what he described as a device for screening the patients for examination so that the head and shoulders were hidden from students. And he wrote that this was a desirable provision against embarrassment and reluctance to face thorough investigation. It actually encouraged more patients to come to his clinics. So what was his character, and what can he be remembered for? He was certainly modest when he described his work as unspectacular, simply personal, close attention to daily routine. And for 20 years, he maintained a detailed record of every patient and published reports for every 1,000 obstetric patients. When he retired, his reports covered 12,000 obstetric cases and over 11,000 gynecological patients. And they were the first reports issued by the department, by any department in the medical school. This insight from his autobiography certainly explains both his directness and what one student explained as handsome arrogance, whilst at the same time being a shy man. I was a single-minded, one-eyed devotee to my task of teaching, having few outside interests, an attitude which, augmenting my inherent shyness, made me less and less gregarious and more isolated and self-sufficient. This is a famous caricature of medical school staff showing Sir Bernard on the left, perhaps illustrating some of his feelings towards some of his academic colleagues. So Horace Smirk is the one on the right with the immensely long stethoscope. Apparently that was for real. Here are some passages and what Sir Bernard thought about them. I was despondent at the disappearing class of mentors with a background of general practice, being replaced by men of specialised training who from the outset of their career aspire appointments in medical schools. And this is what he thought about the requirements of a professor. The role of a professor as the head of a team must remain that of a teacher as well as a mentor. He should personally engage in the practical as well as the systematic instruction, be willing to take a full share of the even elementary classes, and not be content to emerge occasionally from his laboratories to utter some pontifical remarks or deliver an infrequent lecture. He is appointed to teach and give students the benefits of his own practical knowledge and experience. If he has not had enough of these, then his appointment was a mistake. I don't think Sir Bernard would approve of today's standards to become a professor. He wrote, "Today there is talk of surgery or obstetrics as a university career, a conception that is absurd and dangerous. They are both crafts, the exponents of which must be in daily contact with their practical applications if they are to remain good craftsmen and teachers." And then, when vacancies occur, advertisements for successors put more and more stress upon research. Chairs of essential practical subjects are being filled by men who are undoubtedly able scientists, but of limited clinical experience. I'm not sure that's true today. Sir Bernard's legacy was immense. That he was knighted speaks for itself. As well as developing the very first obstetrics curriculum, he was heavily involved in medical politics, at one stage being the president of the New Zealand division of the British Medical Association. He is regarded as the father of New Zealand obstetrics and did so much to enhance the standards of the profession in New Zealand. He achieved immense satisfaction in raising the standards and safety of childbirth, as this slide testifies, in the dramatic reduction of maternal mortality that coincided with his tenure. And after his retirement, Sir Bernard served on the Otago Hospital Board for 7 years and was a major advocate in supporting the new and bigger Queen Mary Hospital, Queen Mary No. 2. And of course, he was the driver behind the very first Queen Mary. He spent many years battling for this new hospital, even though each pound of the cost was to be matched by the health department. He described the local hospital board as showing no encouragement. Some old members, with their feet in the 90s and their heads in the clouds, still held that the existing miserable facilities were satisfactory, and many held that it was the business of the Department of Health to look after maternity needs. And worse still, the government reneged on building the promised hospital. Funding for the hospital was finally settled, but had a reduced capacity. It was to be a 44-bed hospital, but in the end there was only enough money for 26. The decision to limit to 26 was regretted almost from the start, with the baby boom of the post-war years soon beginning to impose serious pressures on hospital beds. Note the low number of caesareans. This equates to rates of about 2, 3, 4%, but in stark contrast to today's rates of 30%. Almost immediately, plans were put in place to expand the building, and the extensions were eventually opened in 1952 and comprised an antenatal clinic and a gynecology clinic, both of which were in existence during my training. For the first time, the maternity hospital had a premature baby unit. There was also the new addition of a flat that was used by registrars and in which Diane and I lived for a year. This recent photograph was taken from Dunedin Hospital's 4th floor and shows the major extensions over here and the registrar flat down there. The 2nd floor, by the way, was accommodation for nurses. Due to regulations for the control of sepsis, they could not live in the nurses' home where they might contact nurses who had been nursing septic cases. Now, that Queen Mary is now occupied by the Surveying School. Sir Bernard retained his chair until age 68, before being longer than he wanted, and he wrote, "The idea of finding a successor was hampered by the war, not supplying well-trained aspirants." As to a successor, he identified Lawrence Wright, who had a distinguished war record and attained the rank of Lieutenant Colonel. As Bernard Dawson wrote, his post-war training gained him higher qualifications and experience in London with a promptitude that beckoned energy and ability. Some of the selection committee thought him too young for the responsibilities of the professorial chair, but Sir Bernard pushed hard for his appointment, as he knew him well as a student and as a house surgeon. As is seen here in this photograph, he had considerable respect for his character and attainments, and he wrote, "The future amply justified this faith in a young man." Lawrence Wright was appointed as the 2nd professor in 1951, and I had the privilege of working with him during my training as a house surgeon in 1975, then during my registrar years from 1976 to the end of 1978. One of Lawrence Wright's early visions was to have even a bigger hospital that would accommodate both clinic patients and those managed by general practitioners, a so-called open hospital. The plans were actually drawn up before the extensions of the first Queen Mary were completed, and it took another 10 years of deliberations before Queen Mary No. 2 was opened in 1961. It was intriguing to note that the sites considered for Queen Mary at the time included Maranotu, Waikari, Parkside, all ultimately becoming other medical institutions. So this became Queen Mary No. 2. An early blow in the development of the new hospital was the realisation it was going to be too expensive, and one of Lawrence Wright's accomplishments was his persuasion to retain the top floor, but as a shell for future use. For the first time in a modern obstetrics hospital, it included a caesarean section theatre. And this was a major accomplishment as Lawrence Wright had a great deal of resistance from Dunedin Hospital. He wrote, "Theatre sisters were a formidable breed, known to guard zealously their domain and resenting any attempt to carve off individual empires." I'm sure they're not like that today. Lawrence Wright oversaw some major advances in obstetric practice, including the integration of anaesthetic services into Queen Mary, but also neonatal care, that eventually found a modern home in 1971 with the opening of the shell. And this photograph was actually published in the Otago Daily Times just a few weeks ago with Donald Malcolm's obituary. This enabled the total care of all mothers and their babies in the same building. It is my impression of reviewing morbidity and mortality statistics of the period that since the first Queen Mary was opened, the standard of obstetric care has been of the highest order. In Lawrence Wright's tenure of 30 years, not one patient under the care of the clinic died. There were 10 deaths in the period, all emergency cases and frequently not related to pregnancy. In his tenure, he developed important clinical collaborations with hypertension and diabetes specialists, and maternal and neonatal outcomes were excellent. He was proud that no case of eclampsia occurred in any of the clinic patients under his care. His most endearing quality, I believe, was his ability to work with his juniors almost on equal terms. His ability to nurture the highest skill set in whatever you did. He always acted as an assistant to the junior, who he regarded as the primary operator. I cannot ever recall when he was the primary operator. His attitude was, if your deputy is not learning to do things better than what you do, you're failing in your task. And this is a quality I've tried hard to declare in my own teaching and mentoring. It was no wonder that as a relatively young registrar leaving New Zealand for the United Kingdom, my skill set at operative delivery and abdominal surgery was as good as one could ask for. It is not surprising that with this trust and leadership came, I believe, Lawrence Wright's greatest achievement with the engagement of primary care and routine obstetric practice. Queen Mary No. 2 became a unique environment in New Zealand where GPs could stand side by side with specialists and practice their medicine in obstetrics in a public hospital. There was no doubt that under Lawrence Wright's tenure, Queen Mary was a renowned institution that attracted many famous visitors, world leaders in obstetrics and gynecology, were frequent visitors, and our department archive has numerous photos of distinguished people who came to Dunedin. Sir Lance Townsend from Melbourne is on the right, was a frequent visitor, and on the left is Sir Alex Turnbull, who was a president of the British College. So was Sir Hector McLennan on the left, and a young Beau Fitzgerald on the right. This photograph was first published in the Dunedin Evening Star, and it is of interest that Sir Hector told the reporter that test tube babies are further away than interplanetary travel. Actually, the first IVF baby just came 30 years later. This photo is of another college president, Sir Arthur Bell on the right, with Sir Bernard Dawson, a photo taken shortly before Sir Bernard's death. Since Lawrence Wright's tenure, I don't think we can boast as many visitors as he managed, but we might claim the most famous, as Dave suggested. Here we have both Lawrence Wright and Dick Seddon with Lord Robert Winston, who has visited our department on 2 occasions. Other fond memories I have of Lawrence Wright included his exhilarating speech at our Queen Mary 60th anniversary celebrations 15 years ago. Another was the support and pride he had for his midwife colleagues, and most of all, his patients. This photo captures some of the fun times. The midwife scrum at the annual rugby match with the doctors. Alas, this annual event was last played in 1978 when I was a registrar. The matron put a stop to it after one of the midwives suffered a fractured collarbone. Well, that was one version of the events. I suspect it was because she didn't approve of the communal shower we had afterwards. Dick Seddon became the third Professor of OMG in 1981, and I had the privilege of working with him from 1983 until his retirement in 1992. It is intriguing he shared the same exact name as New Zealand's longest-serving Prime Minister, and it is also ironic that where the Premier, Dick Seddon, introduced St Helens Hospital, the St Helens Hospital network in New Zealand, it was our Professor Dick Seddon who had an influence on their closure. With the building of the new high-tech women's hospital in Wellington, it wasn't logical to have both the new hospital and the old St Helens. And contrary to the accolades for the Prime Minister Seddon for making St Helens possible, it was R.J. Seddon, gynaecologist, who got the flack from the public outcry for closing them. As it happens, Dick was a distant relative of the famous Prime Minister. His grandfather was a cousin. Dick graduated in 1953 and was taught by Lawrence Wright. Here is a photograph of Dick and his fellow students on their obstetric attachment. He describes his experience in Queen Mary as being like a gun crew with position by numbers. Number 1 was the accoucheur, number 2 held the leg, number 3 would clamp the cord, down to number 6 who scrubbed the floor. Dick recalls his first birth to his horror was an unexpected stillbirth. Dick began his postgraduate obstetric training in Dunedin in 1959, and ultimately he began a successfully academic career in 1965, especially in reproductive endocrinology. Amongst his other early accomplishments was the introduction of laparoscopy into New Zealand, and he performed the very first procedure from a makeshift laparoscope made from a colposcope. Dick was appointed to the Foundation Chair of Obstetrics and Gynaecology in Wellington in 1975, and from there his service to obstetrics and gynaecology grew immensely, serving on numerous governing bodies in New Zealand and internationally. These included his presidency of the New Zealand College and working for the World Health Organization on the Maternal and Child Health Committee. Perhaps his most important achievement was the work he did for the Asia and Oceania Federation of Obstetrics and Gynaecology, leading the design and content of its education program. This federation is an amalgamation of all the colleges of obstetrics and gynaecology in Oceania and Asia. He would have become its president if it had not been for his health. That also shortened his time in Dunedin. He remains as one of the Federation's 18 fellows. Only 18 can be held at any one time for living members. He was an inspiring teacher, and his legacy in teaching obstetrics was the idea that pregnancy was an interaction between the fetus and the mother, and the fetus was the dominant party. This is now universally accepted, but at the time was radical thinking. It was Dick Seddon's tenure that Queen Mary introduced the alternative birthing unit that was closely linked to the delivery suite on the first floor. It was designed so women could labour and deliver in an atmosphere similar to a private home. It had a main bedroom, linking kitchen and second bedroom, and in this photo our two sons are entertaining themselves, whilst in the main bedroom Tom Fittist and Sally Pearman are nattering away, seemingly oblivious to Diane's labour. It was here in December 1984 that our daughter Sarah was born, and she was the second baby to be born in the unit. This photo shows Diane, Simon and Robert, who is holding Sarah. Even though I was an obstetrician entrenched with the mind of safety, I was surprised that this was a unique and wonderful experience. The loss of this amazing facility was a huge casualty when Queen Mary closed down in 1990. It was Dick's mentoring and support from my colleagues that enabled me to develop a renowned microsurgery centre in Dunedin. It was he who came to my assistance with one of the most dramatic moments in my career. So it is with microsurgery and that dramatic moment that I want to present two of my patients, the stories of two women with very different and contrasting outcomes. The first was Sally and her children, who represent the many tens of thousands of women and their babies who had normal births in Queen Mary. And Sally is special to me because her story influenced my own thinking and research into the remodelling capacity of the damaged fallopian tube. She is also a midwife, shown here in the middle, and has become a loyal friend and colleague, being a professional practice fellow in our department for many years, looking after our fourth-year students and practicing midwifery to the highest level. She referred to me in 1985 for a microsurgical anastomosis of her only fallopian tube. Sally and Ken had experienced a devastating loss of 2 of their 3 children, John and Anne, in a car accident. She had only 1 fallopian tube after a previous rather destructive sterilisation, and after microsurgery I advised her of the grim news, that her prognosis was less than ideal, 30% at the most. Sally did eventually conceive, although it took about 18 months, and I was privileged to deliver Kate, who is now 26 years old, and in the following 2 years Matt and Campbell arrived with no period of fertility delay whatsoever. And this is 20 years later with their older brother Rob, who survived the car accident. Prior to this experience with Sally, I had considered the possibility of pregnancy's regenerative abilities, and Sally's own experience seemed to have suggested this. Indeed, when I sterilised her a year later, her tube was entirely normal. To examine the hypothesis that pregnancy improves tubal function, I obtained an HRC grant to follow over 300 of my own cases for up to 8 years, and found that no matter what the original pathology was or how bad the damaged tube, if a woman did successfully conceive a first pregnancy, then her subsequent fertility was close to normal. This remains the only study ever published for this type, and suggested that the tube did regenerate and remodel with pregnancy. But that's where the hypothesis remains. Surgery was not normally a good option for tubal disease, and it was only in the hands of microsurgeons that anyone did any good. The trouble was that there was not enough of us, and it didn't take long for IVF to overwhelm the surgical management of tubal infertility. And so this regenerative hypothesis will never, ever be confirmed. For Bronwyn, her story is very different, and she represents the adversity that confronts all of us in obstetric practice. In Bronwyn's case, she not only lost her baby, but she also lost her uterus. But what she did hold on to was the extraordinary courage and immense trust and mutual respect to her caregivers, including me, that makes practicing medicine so rewarding despite adversity. Even now, 25 years later, her case is the most dramatic I've experienced in Queen Mary. Bronwyn and Brian had 1 child, Matthew, born 3 years earlier. Her pregnancy was complicated by a placenta previa, and at 27 weeks she had a torrential hemorrhage, for which I was called about midnight as the obstetrician on call. By the time we got Bronwyn to theatre, she had lost probably 60% of her blood volume. She was in dire straits that required the most expert of resuscitation and immediate delivery. Rhys James was born by caesarean section, but in spite of initial good progress, he died at 18 hours of age of severe respiratory distress syndrome. For Bronwyn, my personal battle had only just started. She was bleeding torrentially, and the only way we could save her was to physically compress all major bleeders and try to stem the blood flow, while the anaesthetist, Dr. David Jones, who's also in the audience, fought to get her blood pressure back. With her blood pressure recovering, I had to perform a hysterectomy to save her life, but releasing the compression only increased bleeding again. And so for the next 3 to 4 hours, we alternated between surgery and resuscitation before we had control. I had called Dick Seddon to help me, and by the time we finished, Bronwyn had lost and had replaced 3 times her blood volume. This is Bronwyn and Rhys together, unfortunately after he had lost his battle. Bronwyn made a full recovery, and she and Brian requested surrogacy using her sister-in-law, and was the first ever IVF surrogacy attempt in Dunedin. This is where we obtained eggs from Bronwyn, and through IVF the resulting embryo was transferred into the surrogate. Sadly, the pregnancy miscarried, and Bronwyn and Brian did not pursue any more treatment. They adopted Michael in 1995, here being fed by Matthew. About a year after my experience with Bronwyn, the Otago Health Board had second thoughts about the future of Queen Mary. The Finance Committee had argued that the current building was too costly and a shift to Dunedin Hospital was appropriate. At stake was the loss of identity of Queen Mary and the loss of the alternative birthing area that still remained the only one of its type in New Zealand. This is what our midwives thought about Professor Michael Cooper, who was the chairman of the board. The intended move raised much public ire. Even the Dunedin City Council was horrified to learn that there had been no consultation with clinicians, and that has a familiar perpetual ring to it. A protest march of 600 did not change things, although on the day of the march, Professor Cooper assured everyone that closure was only one of the options being considered and that relocation would not happen if the present high standard of maternity care could not be guaranteed. Even a final decision 1 month later to relocate was countered by platitudes from the board's chairman, still trying to save face and dealing with petitions signed by 20,000 people. This attitude by the board is in distinct contrast to that held in 1987, where during the 50th anniversary of Queen Mary, Professor Lawrence Wright described Queen Mary as the jewel in the Otago District Health Board's crown. No other institution can have had such an effect on the lives or welfare of the citizens of Dunedin. Leading the charge against closure was Tom Fittis. Here is a photograph captured by the Otago Daily Times, and another delightful photograph that appeared in the same paper. All of this was ignored, and Queen Mary was finally vacated in March 1990. It was bought by the university and is now a hall of residence, Hayward College. I often reflect on what might have been. The enormous space issues we now have in Dunedin Hospital may have been averted if we had retained this building. The third Queen Mary opened on the 16th of March 1990, not as a hospital, but as a centre. The staff took some comfort from the decision by the board to build a purpose-built unit in the ward block with its own entrance and identity. Although it has formed the working environment for me for the last 23 years, it doesn't quite capture the presence of a standalone building. In my view, the identity of Queen Mary has sadly diminished. Even some birth notices refer to the delivery at Dunedin Hospital and not Queen Mary. But not so the staff. In my 40 years working with obstetrics and midwifery practice, I have had nothing but respect for the working relationship between the doctor and the midwife. And I do want to share with you some images of the amazing people that I've worked with. This is my favourite photograph, showing all the attributes of midwifery and maternity care. The photo is of the late Ruth Moore, holding baby George, who's Celia Devonish's first child. This photograph captures the purity, sensitivity and warmth of the midwifery profession that I'm so proud to be part of. And I know all of my predecessors were equally as proud of this relationship. This photograph not only captures the essence of a doctor and midwife relationship, it also describes two people that have been important to me since I started work as a house surgeon in 1975. The first is Beverly Henderson. They are Beverly Henderson and Murray Wyatt, captured here at the Jubilee Ball last year. Beverly was probably the first midwife I worked with when I entered obstetric training and led the delivery suite team for many years, including the difficult transition period between Queen Mary number 2 and the Queen Mary Maternity Centre. And Murray was a loyal GP, a colleague and friend, and had an immense reputation. Murray has probably delivered more children than anyone in Queen Mary. With his retirement, so went the backbone of the GP obstetrician that no longer exists. I do want to honour Eleanor Cunningham in this photograph at last year's Jubilee Ball, and on the right is Bunty Graham, and these are the only people I know of who actually worked in all of the 3 Queen Marys. I do apologise if I have omitted others that I'm not aware of. Queen Mary has graced many wonderful matrons, the first being Phyllis Clifford. And in this photograph, Miss Nora Corson is at the back in the middle. She followed Miss Clifford as matron, and in this unique photograph in 1987 at the 50th anniversary of Queen Mary, Nora is seated in the front row there, and most of you will know Nairi Cornell, who did so much for midwifery in the 70s and the 80s. This brings me to the fourth professor, Don Wilson, who was appointed to the chair in 1995. Don came to New Zealand in 1980, having completed his training in Glasgow, Zimbabwe, then Manchester. Even as a registrar, he formed a reputation in obstetrics, as this early publication suggests. As a registrar, he was developing a name for himself. But his other strong interest was in urogynecology, where he has ultimately excelled. This photograph was taken at the 60th anniversary with Lawrence Wright. Don has, in my view, been the most academic of all the professors. He is not yet retired yet, but already he has published over 150 peer-reviewed articles, and in his time in the department secured 24 grants. This is a phenomenal effort for someone who was also responsible for a clinical load involving on-call work and many nights of broken sleep that on-call obstetric duties demand. His early tenure also meant heading the clinical department as well, and so one wonders how he could have achieved what he did. For those who know our current setup, it was he who initiated the handover rounds, and at the beginning we were in rather cramped quarters in the tea room in the delivery suite. In my view, it was obstetrics' loss that he gave up this discipline in the last 10 years of his working life, for he was a formidable teacher in obstetrics and practiced to the highest of standards. And although obstetrics had a loss, it was urogynecology's gain that he has become one of the international leaders in the field, both as a clinician and a researcher. I guess his obstetric bent is shown in this urogynecology work that he is now most recognised for, initiating the PROLONG study, the international longitudinal study of women after an index birth. And this started as recruitment for a randomised controlled trial, but it converted into something much larger than he could have realised at the time. It is planned to continue the study with international collaborators until 2015 to provide unique 20-year data. He also excelled in teaching and had a unique style that engaged his students. And this is one of his slides he began some of his tutorials with, of his trademark being to involve his students in their learning. Tell me and I forget, teach me and I remember, involve me and I learn. And who can forget the start of this tutorial? He would have all his students on their feet conducting their way to their learning. I have certainly been proud to be Don's colleague, and for many years he led both the academic and clinical departments, promoting a happy department with many fun times. And here is a photograph of some of that, of a sense of humour, of the department photograph. And then this, we made a very happy environment. In this one, he is being delivered by forceps into his new position as professor. And so I come to Jane and her story to finish this lecture. For some, the simple notion of normal reproduction is seemingly out of reach, and this was certainly the case for Jane and Andrew, who were referred to our service after Jane had experienced 10 miscarriages. A miscarriage is a burden that many women experience, but to do it 10 times is devastating beyond belief, especially if it occurs in mid-pregnancy, as was the case with Jane on a number of occasions. Arguably, it is my specialty's greatest challenge to find a way to help, and unfortunately for us, there are no books or journals or any learned pathway that we can pick up to find a way to prevent it. We need to rely on instinct and belief, but to find a way gives no greater feeling of satisfaction and professional achievement. For Jane and Andrew, there was a happy outcome, and it came about because of the unwavering trust and respect for our service, but also the dedication and skill of many people, beginning with our high-class IVF unit, our dedicated obstetrics and midwifery teams, and probably above all, our fantastic doctors and nurses in the neonatal intensive care unit. So I want to end by briefly giving Jane's story. She had a condition called adenomyosis, which means that she has multiple sites of bleeding within the uterus, which leads to scarring and the inability for it to grow and function properly in pregnancy. To try and overcome this, I prescribed 6 months treatment with a gonadotropin-releasing hormone with the aim of shrinking these bleeding sites. And after 6 months of this, using IVF to try and get her pregnant quickly. We did so, and Jane conceived successfully, but unexpectedly had a twin pregnancy to manage. We had a twin pregnancy to manage, something that added a great deal of complexity. Despite being an inpatient, at 18 weeks, she experienced a major setback in that her first twin, Jessica, suddenly miscarried. Jessica was far too premature to survive, and so you'll appreciate that survival was only possible from about 24 weeks. And so Jane and Andrew and all her caregivers had at least 6 weeks of anxiety to reach that milestone. For a second twin to be retained is an unusual event, and in Queen Mary's 75 years, I can only imagine this would have happened only a few times. But with a dedicated team effort, we got another 7 weeks before Jane began to bleed. Emma was born by emergency cesarean section with a weight of 730 grams, that is 1 pound and 10 ounces. And these are some other photos of Emma, a ring finger on her arm. A ring on her arm. And a favourite of mine with Emma and Andrew. Emma never looked back, and in this photo, this is the photo of her this year, and I'm very, very proud that she is also here in the audience today. Ladies and gentlemen, and Emma, those are the 3 Ps of Queen Mary. Nō reira tēnā koutou, kia ora tātou katoa. Thank you.
It made me think of several things. First of all, I thought that it underestimated your effect on our medical school in terms of teaching a critical appraisal of medicine. Both obstetrics and neonatology and paediatrics are full of things that we've actually done wrong. And you've taken a lead part in actually teaching us and both the staff and the medical students around how to look at evidence and actually decide whether what we're going to do is correct or not. I think that's underplayed, and I think that's actually been one of the key characteristics of your teaching career, for which I personally have really appreciated. So thank you very much, and I want to see, that's really so important, I believe, that that we cannot mention, not mention it really. The look at history is important because it brings to mind the aphorism that those who ignore history run the risk of repeating the past. And in fact, listening to you, I could see the repetitions that can occur with history, even in the current time, when there's been issues around the fertility service and how it moves forward, and how decisions about a building can actually have consequences some 10, 15 years later that you regret. So I think there is a lot to learn from looking back at history, even though we fix our eyes on the future and say, what are we going to do and how are we going to do things better? And I think the critical appraisal leads to one, and looking back at history leads to saying, let's not make those sort of mistakes again. So thank you very much. I think that's been a great lecture. I'm sorry I had to leave at the very beginning. You might have wondered what had happened, but I'd forgotten something. I suddenly realised that I didn't have a token of appreciation which was sitting in my office, so I had to run back to my office and get a token of appreciation, which was sitting there for me to forget. So I would really like you to accept this as a token of the appreciation the university has for what you've done tonight and in the past. This is the something to go up on the wall to remind you of the occasion, and this is a more useful, perhaps, token of appreciation that you can spend in any way that you like. Thank you very much. Really appreciate it.